Welcome to the April 2023 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
And I'm Lisa Yan, Director of Programs and Outreach for LACNETS.
Today's presentation is on what's new in PRRT. A special thank you to our supporters, Advanced Accelerator Applications, ITM Pharmaceuticals, Lantheus, and Trinetics. LACNETS stands for Learn, Advocate, Connect, Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. Our LACNETS team includes Heather Davis, Associate Director of Advocacy and Outreach. The board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joyce and Daisy, and NET patient Mary Dunleavy, who has been living and thriving with NET for 19 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance. For more information, visit lacnets.org/supportline. I'm now going to hand it over to Lisa to share some important tips about today's program.
Thank you, Kavya. This webinar is being recorded and can be viewed on the LACNETS YouTube channel shortly after this broadcast. Our YouTube channel features approximately 300 videos. Use our playlist to find videos on imaging, PRRT, surgery, medical therapies, liver-directed therapy, nutrition, diarrhea, lung nets, high-grade nets, and much more. We also have a playlist for those who are newly diagnosed, as well as a playlist with Spanish videos. You can find guided meditations, patient stories, and past conference videos. Follow LACNETS on social media to stay up to date on our upcoming events and NET news. We are on Facebook, Twitter, and Instagram with the handle @LACNETS. And be sure to add us to your Safe Sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this webinar are the expert's personal opinion. Please contact your medical team with questions or concerns about your individual care or treatment. Today, we are excited to discuss the very popular topic of PRRT. Today's presentation will be covering advanced information about current and future PRRT trials and topics such as dosimetry. For those who may be newly diagnosed or new to the topic of PRRT, we encourage you to check out our past PRRT content, including blog posts and videos that cover the basics of PRRT. I'm pleased to now introduce our speaker, Dr. Amir Iravani. Dr. Iravani is a nuclear medicine physician and an associate professor of radiology at the University of Washington and the Theranostics director at Fred Hutchinson Cancer Center. Before his current role, he worked at the Center for Molecular Imaging and Therapeutic Nuclear Medicine, Peter MacCallum Cancer Center in Melbourne, Australia. He completed his training in nuclear medicine and internal medicine in Australia, followed by a fellowship in molecular imaging and radiopharmaceutical therapy at the esteemed Peter MacCallum Cancer Center in Melbourne. He joined the University of Washington Fred Hutchinson Cancer Center team in 2022 and has been working very hard to advance the field of NET. Dr. Iravani is actively involved in multiple practice-changing theranostic clinical trials and contributed to multiple groundbreaking publications in this field. He's currently a member of multiple national committees in theranostics, including the Board of Directors for the Society of Nuclear Medicine and Molecular Imaging Theranostics Center of Excellence and the PRRT Dosimetry Working Group at the National Cancer Institute. All of this is to say that Dr. Iravani is working very hard on your behalf and my behalf to advance the field of NET so that we can live a very good quality of life despite living with the disease. Welcome, Dr. Iravani.
Hello, everyone. I'm Dr. Amir Iravani. I'm an Associate Professor of Radiology and Theranostic Director at Fred Hutch Cancer Center. I'm honored to be invited by LACNET to present on this exciting title of the What's New in PRRT. These are my disclosures. So it's been over 4 decades of work from the first time that a somatostatin analog was developed to target the somatostatin receptor type 2, which is commonly expressed by neuroendocrine tumors. After initial developments of analogs, they were thought that actually could be labeled with radioisotope and could be used for diagnosis and treatment of neuroendocrine tumors. As you could see, in 1990, there was development of the indium-111 pentatriotide, which was FDA approved for imaging of neuroendocrine tumor. And a couple of years later, the indium-111 was used to treat neuroendocrine tumors because of the Auger electron emission of this agent. As you could see on the top, this is a construct of a radiopharmaceutical when the peptide is in a rectangle picture, attaches to the receptor on the cell surface of the neuroendocrine tumors, and on the other side is attached to a radionuclide by a linker. And the chelator, which is like a cage, contains the radionuclide. So when the entire structure gets attached to the receptor, gets internalized within the cell, gets trapped within the cells, and starts to radiate the cell. So this concept was used to image and treat neuroendocrine tumors, as you see with the indium-111. And then later on in 2000, the first patient was treated with lutetium-177. So there was over a couple of decades of experience with lutetium-111, initially used in Europe and outside of US for treating neuroendocrine tumors. A large number of patients were treated on registry and compassionate-based access. In about 2015, the NETTER-1 trial was started internationally and started to recruit patients to these phase 2 trials. So this pivotal trial was published in 2017, and after that in 2018 was FDA approved in the US. So it's been accessible from 2018 as a standard of care treatment. Meanwhile, we also have a more accurate imaging using gallium-68 in 2016, and later on in 2020 we have also gallium dotatate and copper-64 dotatate imaging. This is the result of the NETTER-1 trial, when you see there is marked improvement in progression-free survival of the patients who were treated in lutetium arm plus long-acting somatostatin analogs compared to those who received only long-acting somatostatin analogs, although it was even double dosed. So it was 79% decrease in the risk of progression of these patients. And you can see on the left side, there has been also quite improvements in the anatomical response rate of these patients, which led to FDA approval of this agent. It also attracted the oncology attention, and American Society of Clinical Oncology in 2019 recognized lutetium-177 dotatate as one of the 5 advances in medical oncology. Later on, the long-term safety and efficacy of lutetium-177 dotatate or Lutathera was also published. As you can see here, there was a longer follow-up. Although there was numerically, there was improvement over 12 months of survival in patients who received lutetium dotatate, it did not reach statistical significance. And there were some discussion in medical oncology why this didn't happen. There were a few factors to consider. First of all, this study was not powered to measure or compare the overall survivals of the patients. As we know, the neuroendocrine tumors is a low-grade tumor and progresses very slowly over time. And the progression-free survival appears to be a more favorable endpoint for the clinical trials. In the control group, we see that 36 patients of the patient later on received PRRT or lutetium dotatate treatments. And also during the long-term follow-up of these patients, because these patients cycle over many treatments, also about a fourth of these patients received also other anti-neoplastic treatments. So these factors might have contributed that the survivals did not reach statistical significance. However, the important factor to consider is lutetium dotatate improves the quality of life of the patient, as demonstrated again in the NETTER-1 trial. We see the global health status of the patient, or the time to deterioration of the global health status of the patient, or physical functioning of the patients was longer in patients who received lutetium dotatate. And also improves the symptomatology of the patients as well, which is considered particularly important in this group of patients. So despite the efficacy and acceptable safety profile of PRRT, we know that not all patients would respond favorably. And lutetium-DOTATATE was just the beginning. Hopefully that we could optimize PRRT to improve the efficacy profile and potential toxicity profile of this treatment. So I grouped the 4 advances in the PRRT, 4 groups of advances in PRRT as optimal timing and sequencing of treatment, or expanding its indication beyond mid-gut tumor, which was used in neuroendocrine tumor, optimizing the treatment schedule, using rational combination therapy and synergistically using other agents, which is proven to be effective to improve the efficacy of this treatment, and also using other novel radiopharmaceutical or isotopes, and finally using biomarkers to predict and prognosticate this treatment. So optimal timing and sequencing and expanding indication. So there are a number of guidelines developed over years. You see Society of Nuclear Medicine, European Society of Nuclear Medicine as well, and neuroendocrine societies, including North American neuroendocrine societies or European endocrine societies, develop guidelines to use and how use the lutetium-DOTATATE treatment for patients. We also see at the bottoms that even in the oncology communities, for example, European Society of Medical Oncology developed a guidelines, as well as the NCCN in the United States. So looking a little bit detail in the timing and sequencing of this treatment, for instance, this is a NCCN guideline 2022. We see pancreatic neuroendocrine tumors. And when we look at where the PRRT is located in the tree of the decision-making for the clinicians, we see there are a lot of options available for them, and they're all put in parallel. And also the guidelines basically mentioning that because of the lack of prospective data, it's basically a decision between the clinician and the patients to consider patient's factors, patient desire, and disease considerations to choose any of this treatment over the other. European Society of Medical Oncology has a more granular guidance in terms of where PRRT needs to be, for which patients needs to be started. For instance, in a small bowel or small intestine tumors, when the tumors have lower grade, for instance, early G1 with Ki67 less than 10%, PRRT is put up front after progression on somatostatin analogs. But when the tumor grades increases, we see it falls behind everolimus, for instance. In the pancreatic NET, or neuroendocrine tumors, is actually more complex because there are more available treatment options. Apart from targeted treatment like everolimus or sunitinib, we also see chemotherapy agents like Captem as well. So the PRRT falls even behind those agents, not only in the lower grade tumor, but also in a G2 tumors as well. At the same time, we see Dr. Kroening, which had a pivotal role in development of PRRT, mentioned that maybe in the pancreatic neuroendocrine tumors with the Ki67 of less than 10%, we could put the PRRT, bring it a little bit forward, and upfront, put it in parallel with the other targeted treatment and chemotherapeutic agents at an equal choice. And even we were thinking whether we could also use PRRT even with the higher grade tumors, also bring it at least in parallel or as an equal choice to the other targeted and chemotherapeutic agents in higher grade tumor, even with the newly grouped G3 well-differentiated neuroendocrine tumors. So this is the beginning of a lot of prospective data, which is very promising and very encouraging. So this study is colorandom, was the first phase 2 trial of lutetium-DOTATATE in pancreatic neuroendocrine tumor. There was a randomized study which randomized either to sunitinib or lutetium-DOTATATE, and we see, despite a relatively modest number of patients, of 84 patients which are randomized, because of the large effect size of the lutetium-DOTATATE, we see a quite significant difference in 12 months progression-free survival of the patients, of 80% in lutetium-DOTATATE compared to 42% in the sunitinib arm. which also led to patients having longer progression-free survival. Although the oncologists think that this trial basically was a practice verifying study, which verified the practice that they already had and the general acceptance that the lutetium dotatate may be a better agent compared to sunitinib. But this was the first randomized trial in pancreatic NET and is of quite an importance in the clinical oncology and nuclear medicine. But we have now a number of other randomized trials as well, as I've listed a few of them here. You could see the NETTER-2 trial, which has also finished recruitment, had a similar design to NETTER-1 trial. The same agent was used and the same concept of randomizing PRRT compared to long-acting somatostatin analogs compared to the double dose long-acting somatostatin analogs. But in this study, we see the expansion of the indication to the grade 2 and grade 3 of the patients as well, up with a Ki67 of less than 55%. So this, again, bring the PRRT in an upfront with or without prior progression on long-acting somatostatin analogs. And in this study, the crossover was also allowed. But let's look at other studies as well in a little bit more detail. So COMPETE trial was another randomized trial which finished recruitment last spring, about a year ago. It was a multi-center phase 3 trial, and the agent which is used a little bit different to the lutetium dotatate. This is lutetium dotatate, and the treatment interval was 12 weeks instead of 8 weeks in this study. The comparison was between the patients of G1 and G2, comparing it to the everolimus. So there are some highlights about this study. This study also includes first line without prior somatostatin analogs. And also in this patient population, patients had either monotherapy or combination with somatostatin analogs in lutetium dotatate arm. Pancreatic neuroendocrine tumors was also included, and quite a comprehensive dosimetry was performed in this study, which the results are going to be very important to know for potentially future use of dosimetry modulated trials. COMPOSE trial, which is currently open and recruiting patients, is basically recruiting gastroenteropancreatic neuroendocrine tumors, is expanding it to the higher grade tumors with the Ki67 of 15 to 55%. One of the interesting things in the study is using FDG PET also to exclude patients who might have sites of disease which are not expressing somatostatin receptors, but they are FDG avid, and also bringing it forward again and an upfront treatment in these high-grade tumors, even to patients who have no treatments before. So this study using up to 6 cycles of treatment, and one of the other differences in this study is the interval between cycle 1 and 2 used is 6 weeks, which is kind of proportionate to the higher grade tumor, and considering the higher grade tumors growing with a faster rate, so the interval was decreased in the first and second cycle, while the subsequent cycles are 8 weekly. So again, interestingly, this study is using a comparator arm, which is active treatment, either everolimus, FOLFOX, or CAPTEM, which are based on the physician discretion and physician choice. In this study also, the full genomic analysis and dosimetry will be used, which I think would be important for the field. So this study is a randomized phase 2 trial of comparison between the CAPTEM and lutetium dotatate in pancreatic NET. This study is led through a Cancer Cooperative Alliance by Allah and SWAG. The PIs of this study is Dr. Hobadi and Dr. Suarez. Is a randomized trial of G1 and G2 well-differentiated neuroendocrine tumor and G3, and comparing the lutetium dotatate compared to CAPTEM. This study is important because also provide a prospective data on pancreatic NET and compare it to the CAPTEM, which is currently also considered a choice for these patients. Expanding the use of PRRT to bronchial NET is very important. We have a small number of studies which have a limited number of patients, either prospectively or retrospectively, all single-arm studies, as I've listed here, a number of them. And we see in bronchial neuroendocrine tumors, the response rate and disease control rate is very promising, particularly in patients who are selected based on somatostatin receptor PET and they have adequate expression of somatostatin receptors, with the promising progression-free survival and overall survival. So there was a critical need to design a prospective study for bronchial NET, which is now also open to recruitment, again through NCI and by Cancer Cooperative Group Alliance. Dr. Hope and Dr. Para are PIs of this study. This study randomizing the patients to lutetium dotatate compared to everolimus. The primary endpoints, as other studies, is progression-free survival, and the crossover is also allowed. So it's a very important study, and we're hoping that this provides a randomized evidence for efficacy and safety of PRRT in this group of patients. Retreatment is important. So from 2018, now the patients being treated as with PRRT, and now we're reaching the point in the US and the patients may need retreatment. And the question is raised whether the patient can also have the similar benefit that they had initially with PRRT. This is a systematic review and meta-analysis by Dr. Strasberg, looking at a number of studies that have been performed in a retreatment setting, and the patient who had initial benefit now progress and they get retreated with the lutetium dotatate. And we see there is almost similar safety profile to initial PRRT and relatively encouraging progression-free survivals in these patients. So basically this initiated a concept of NET retreat trial, which is in the final stages of protocol development and hopefully will be opened anytime soon, basically randomizing the patients who at least have 12 months of disease control with the prior PRRT, and this patient will be receiving either 2 cycles of lutetium dotatate or be randomized to everolimus. Again, this study is run through NCI, and a Canadian Cancer Trial Group and SWAG are with the chair of the studies, Dr. Sen and Dr. Chahan. What about pheochromocytoma and paragangliomas? We know that many of these tumors also express somatostatin receptors, and this lutetium dotatate has been used off-label to treat these patients, and also outside of US has been a longer experience with this agent to treat these patients. So this study is now open at NCI and is a phase 2 study, single arm, and in patients who are surgically inoperable or metastatic and progressive by imaging to receive lutetium dotatate treatment. Another group of patients which important are adolescents, 12 to 18 years. We know it's relatively rare in this group, but it's important to know the efficacy of the lutetium dotatate in this group of patients. And as you see in this study is a multi-international study with the primary endpoint of dosimetry and adverse events. So dosimetry is in this group is important. As I said, this patient may live a long time, and it's important to know exactly what amount of radiation is going to be absorbed within the normal tissues in this group of patients. So this study has 2 subsets. First, G1 and G2 well-differentiated gastroenteropancreatic NET patients, and also pheochromocytoma and paragangliomas also getting recruited in this study. So the second part of the current and future perspective is how we could optimize the treatment schedule. We know all treatments receiving the same amount of radioactivity, 200 millicuries or 7.4 gigabecquerels every 8 weeks for 4 cycles of treatment. So the question is whether this could be optimized based on the patient and also tumor characteristics. So we know that there is little known about the radiobiological impact of PRRT and tumor and normal organs. And a lot of knowledge that we know from radiobiology of effective of PRRT is extrapolated from external beam radiotherapy. But there is fundamental differences between the external beam radiotherapy and radiopharmaceutical therapy. As you see on the right side, in the external beam radiotherapy, there is a uniform radiation delivered to the sites of disease, regardless of what the site is, and regardless of whether the disease is heterogeneous or not. Although the external beam is very conformal, but this is relatively uniform radiation in a very short space of time, basically delivered to the sites of disease. But radiopharmaceutical delivery is highly dependent on target expression at the sites of disease. And the density of the cells are important as the density of target expression within each cells. But also the size of the lesions are also important, as well as we know the delivery of the position of radioactivity is actually dependent on the path length of the radioisotope, which might be about 1 millimeter, for instance, for lutetium-177. So it's relatively heterogeneous delivery of radiation to the sites of disease, which is dependent on the size as well. And is over time, because these agents work as a drug and they have a pharmacokinetic. So they're enter into the circulating system, they get absorbed into tumor sites, and then gets cleared. So delivery of the radiation is actually over time. So there is a spatial and also temporal heterogeneity compared to external beam radiotherapy. And a lot of thresholds that is been basically driven from external beam therapy may or may not applicable to the radiopharmaceutical therapy. For instance, the 23 gray threshold to the kidney, which is extrapolated from external beam radiotherapy. So I'm giving you an example. For instance, you see two different patients here and the tumor here as well. So you see on the top, there is a tumor with a relatively sparse expression of targets, while the patient in the bottom has more dense expressions of the target, which is somatostatin receptor. And what it translates to the PET scan, when we see the uptake in the lesions is relatively modest in the patient on the top, while it's quite intensive on the patient on the bottom. So what it translates when we give the treatment, so we see much higher crossfire effect in the patient who had much higher expression of the somatostatin receptors. And that would be a predictive factor that could be basically mean that the patient may have a better response. So systemic delivery depends on many factors, apart from the cell density, apart from the cell expression, and also the environments of the tumor as well. So how we can measure this is by doing radiation dosimetry post-treatment. So again, you see two different patients on the left and one on the right side. And when you look at the radiation absorbed dose to the tumor, which is in the yellow and red bar, we see there's a big difference between the radiation absorbed dose to the tumor compared to the normal organs, which is in blue. And what it means that there is a much higher therapeutic index and difference between the absorbed dose to the tumor compared to the normal organs. While when we look at the patient on the right side, we see the absorbed dose to the tumors are only slightly higher than the normal organs. So basically means this patient may have a lower therapeutic index of treatment. And from external beam radiation, we know that the probability of a response to the tumor is dependent on the ratio of the tumor control probability to the normal tissue complication probability. And that difference provides a window, which is called therapeutic window. And it would be important to know how much within that window we can move the administered activity to increase the radiation absorbed to the tumor while we still remain within the normal tissue absorbed dose and radiation. So dosimetry is feasible, and this study basically demonstrated that in over 200 patients, then if we adjust and modulate the dose compared to the 23 gray as a surrogate for the tumor dose, and increase the number of cycles instead of 4, giving more cycles of treatment to the patients to optimize the absorbed dose to the 23 gray to the kidneys, we could see patients who received that 23 gray, in fact, have better progression-free survival, as we can see on the right, and overall survival. And in a small number of the patients, we see that there might be a correlation between the dose response in the tumor sites. So the higher amount of absorbed dose to the tumors mean the higher probability of the patient may have a response. It seems that a fixed number of cycles administered activity might be ignoring the wide variability that we see in absorbed dose to the tumors, which might be in a factor of 10, and non-tumor tissues in which be a factor of 5. But also there are challenges as well to do a dosimetry modulated treatment. We know that the dosimetry could be time consuming. We need consistent methodology to reduce the variability, and we need to have dosimetry facilities and equipments available for physicians to be done in a timely manner, and preferably automatically or semi-automatically. But there are ongoing efforts to overcome these challenges. For instance, the softwares have improved, the camera technology is now improving as well. And Society of Nuclear Medicine and Molecular Imaging also have started initiatives to develop the Dosimetry Task Force, develops a series of publications and guidelines. The efforts have been started to harmonize dosimetry, and hopefully within the clinical trial networks, we could develop a trial which uses the dosimetry to basically individualize treatment for a particular tumor and particular patient. Now we go into the third perspective, which is rational combination therapies. So we know that the radiopharmaceuticals impacts on the cell is by either single-stranded break or double-stranded break, either through a direct impact of the radiation to the DNA of the cells, or indirectly by free oxygen radicals, which causes the DNA damage, and the process of DNA damage response activation starts after initial insult to the DNA. But as you can see, this is a complex process which could be, if we use other agents, which is synergistically causing either DNA damage, for instance, chemotherapeutic agents like alkylating agents or antimetabolite agents, or we may be able to use some other agents which impairs the DNA repair, for instance, PARP inhibitors or ATM inhibitors or other agents which synergistically impairs the ability of the DNA which is already damaged to be repaired. Not also synergistically, we could also use other agents, for instance, using immunotherapy. And as the radiations delivers and changes the environments of the tumors and increases the antigen expression, maybe adding an immune checkpoint inhibitor and immunotherapy can have a more impact on the tumors. So one of the agents which has been studied for a long time, over a decade, is radiosensitizing chemotherapy. As you see, the first study which was published, it was 2011, when a capecitabine, or antimetabolite chemotherapy agent, was used to combine with the lutetium dotatate. And now we have also a prospective study and randomized study, which is done in Australia, is a non-comparative randomized phase 2 trial, which was presented at ASCO. And what we see here, these patients are having higher objective response, the patient who received the combination of PRRT with chemotherapy, but that comes at the expense of higher proportion of the patient having higher grade toxicities, as you see in the red. So is important factors need to be important when we combine treatments. Is patient selection is important. So we using this combination therapy for patient might have a higher risk of progression and also adverse events. As we combining different treatments, we have to be careful about the adverse events that may add up to each other. PARP inhibitors are very interesting agents that have been used, as I said, is conceptually can also enhance the impact of PRRT. In this preclinical study, we see that when the lutetium dotatate combined with PARP inhibitor, there is increasing number and persistence of double-stranded breaks, as you can see on the graphs on the bottom, particularly at 24, 48, and 96 hours, we see there much higher proportion of double-stranded DNA breaks. And that's translate on the right side, you see there is a delay in the tumor growth, as you can see on the green graph, and also improvement in the survival of the mice. A number of studies have now been started to look at combining these agents. For instance, on the top you see a phase 1/2 study combining PRRT with triapem. This study now has moved to phase 2, and recently phase 2 study, which is a randomized study, has been activated through NCI. You could see other study which is combining olaparib with in gastroenteropancreatic NET with lutetium dotatate through NCI. And the third study is also another agent, which is a DNA PK inhibitor, another enzyme which is, again, involved in the DNA damage repair mechanism as well. There are other combination therapies. For instance, combining the lutetium dotatate with ID131 MIBG is an interesting concept, as well as some of the neuroendocrine tumors express neuroamine transporters. And also, as I mentioned before, combining with checkpoint inhibitor or pembrolizumab with lutetium dotatate is also of interest that the UCSF is performing this study. And also, most recently, a study is close to opening, combining sunitinib with lutetium dotatate as well. So the challenges and opportunities here is that the rational combination therapies, in order to show their efficacy compared to the normal or standard of care, needs to be proven in randomized trials. The patient selections is important in combination therapies, as we see, to use it for patients who might have increased chance of progression, and also synergistic toxicities are important consideration in these studies. But other important things as well, which I'm very excited about, is how we could actually modulate the biology of the tumor. So how we could modulate the somatostatin receptor expression. There is little known about epigenetic modulation of somatostatin receptor expression. We know that somatostatin receptor expression could be upregulated, for instance, if we could use HDAC inhibitor, or in this study, DNMT in combination with HDAC inhibitor. And by increasing expression, as you see in the preclinical models on the bottom, there has been increasing in autoradiography on the left side, and also in the uptake of intensity on the right side. We see in the graph that there has been increasing intensity of uptake, which that could translate to better efficacy of the treatment. So what about novel radiopharmaceutical and isotopes? There has been quite exciting advances here as well. I'm just mentioning a few of them. The somatostatin receptor antagonists are important. All the agents that we currently use is agonists. So antagonists are, again, attaching to the somatostatin receptor, but they don't internalize. In the studies, they have shown they can demonstrate higher tumor to background ratio and longer tumor retention, because these antagonists appears to recruit even cytoplasmic somatostatin receptors and recruit them to the cell surface. There are a few agents which is been tried in human, including JR11 and LM3, and they are in phase 1 and 2 trials. What about modulating the pharmacokinetics of the lutetium dotatate? So albumin is one of the most abundant protein in the blood plasma. It's been used in the drug development for a long time. Evans blue, it binds to albumin reversibly without changing the affinity of the peptide to the somatostatin receptor. So by adding Evans blue to this molecule, it shows that the pharmacokinetics of the drug can improve, and it basically can remain in the blood for a more prolonged time. And what it means that, as you see on the graph in the left side, we see there's a longer period of time that lutetium dotatate is available in the bloodstream to get absorbed within the tumor. But at the same time, as there is increase up to 8-fold of tumor absorbed dose, there's also increased absorbed dose to the normal organs, particularly bone marrow as well. So a lower amount of radioactivity needs to be used when these agents is utilized. And there is a first human study which is performed, and other studies are also will be open soon. What about other tracers? We have copper-64 and copper-67 SART8. We know that the short half-life of gallium-68 is insufficient for us to be able to do dosimetry prospectively in patients, but while the copper-64 has a longer half-life, which may allow us to image the patient multiple times after the administration, and that gives us dosimetry calculations to basically plan the treatment. And also there is a copper-67, which is an almost perfect theranostic pair of copper-64, which can be attached to this molecule and be used theranostically, and is a beta emitter. And in this preclinical study, we could see it appears to be highly stable in the in vivo. And there is a pediatric trial, a multi-center dose escalation phase 1-2, which is used in neuroblastoma patient, in pediatric neuroblastoma, which is also expressed somatostatin receptor. One of the other exciting developments is alpha radionuclides. So there are a couple of important advantages of alpha over beta emitters. So the alpha emitters have higher linear energy transfer, much higher than beta emitters. And that basically translates to increased DNA double-strand breaks, which is less affected by the cell cycle phase and less affected by the tumor microenvironment and hypoxia. What it means in practice means that the lower number of DNA hits are needed for an alpha to kill a cell compared to the beta emitters, so in factor of 10 to 100 times. The other important difference between alpha and beta is they have a short path length, and their path length is only 2 to 4 cell widths. So it's a very short path length compared to beta emitters, which might be from 100 to 600 cells. So they deposit their energy very close to the cells where the target's expressed. So basically, it's a highly targeted treatment, as you can see on the graphically on the right side as well. So you see the radius of the cells radiated by alpha is much smaller compared to the beta emitters, but with much higher energies. So there are a few agents being developed. The ones in the bolts are the ones is basically now is moving to the later phase trials. And let's look at some of this a little bit more in detail. So this was a first in human dose escalation of lead-212, which is an alpha emitter, dotamtate, similar to dotatate, but again, targeting the somatostatin receptor. This study recruited 20 patients. 10 patients reached the recommended phase 2 dose. And in that 10 patients, the response rate was quite remarkable. These patients were PRRT naive, but over 80% had anatomical response to the treatments. They did not observe any dose-limiting toxicity or no delay or reduction or cancellations, and there was only modest decline in the GFR at 3 to 6 months after completion of treatment. But it's important to note that sometimes the renal toxicity may take more than a year or so. So it's important to have a longer-term follow-up of these patients as well. So this has now moved to a single-arm targeted alpha therapy for a PRRT naive patient and also for the patient who also progressed on the prior PRRT and is currently active, recruiting in a few sites in the US. The other agent which is also now moved to phase 3 trial is actinium-225, which is an alpha emitter dotatate. The study I'm presenting here is basically in 91 patients, is a single arm study which is done outside of the US in India. And the patient been treated with 120 kilobecquerels per kg. And it was also combined with capecitabine as a radiosensitizer. Over half of this population had previously been treated with lutetium dotatate, so it was a cohort of naive and also the patient who progressed after lutetium dotatate. And partial response in this group was also quite encouraging of 48%. Almost half of the patient had partial response. And we see it seems to be that this treatment was more effective when they looked at in patients who didn't have PRRT compared to the patient who had PRRT, although even in patients who progressed and the prior PRRT is still, the response rate is promising. And now we have a phase 3 study. This is a Action 1 trial, which is developed by RizBio, a company in San Diego, and this is using actinium-225 dotatate versus the standard of care in gastroenteropancreatic NET patients who at least had a 6 months disease controlled with the prior lutetium dotatate treatment. As you see, these patients will be randomized either to receiving actinium-225 dotatate compared to investigator choice of a standard of care, which could be everolimus, sunitinib, or high-dose octreotide. As you see, there is no chemotherapy in the standard of care because of the lack of knowledge about the combination of or sequential use of this agent compared to chemotherapy, as these patients may cross over later on if they are randomized to the standard of care. So the phase 1 of this study has been completed, 17 patients, and there was no dose-limiting toxicity. So very soon the phase 3 of this study will be open across the United States. We talk a lot about alpha isotopes, but also important to note there are some challenges about alpha isotopes. So the alpha isotopes decay scheme, some of them has a little bit complex, and they have daughter radionuclide after initial decay, which some of these daughter radionuclide could have a long half-life. And currently we don't know where, after they unbound from peptide, what would be the fate of those radionuclides. So it's important to understand those, and which may cause some unintended toxicity. So it's important to have a follow-up and long-term follow-up of these patients. Because these radioisotope is in a small amounts, they don't emit much gamma radiation, so the post-treatment dosimetry is relatively challenging. And the other challenge about these agents are access to the radioisotope, which is currently different approaches are taken to address these issues to produce enough alpha isotopes to fulfill the clinical need for these agents. And last but not least are the biomarkers. So the biomarkers are divided to 3: clinical, blood biomarkers, and imaging biomarkers. So this study looks at the clinical score and biomarkers that could help us to predict which patient might respond or which tumor might respond to the treatment. And they basically score the clinical factors, including the symptoms that the patient might have, the bulk of the tumor in critical organs, for instance, the liver, if there is more than 50% of the liver involvement, whether or not there is other treatment options for that particular net of different origin. For instance, thymic neuroendocrine tumor, we have limited treatment options. The site of the disease is important, like peritoneal carcinomatosis, particularly have a poor prognostic implication, and also the number of prior systemic treatments that the patient might have or options that the patient might have also. So these patients are scored based on 0 to 2, and basically, and you see on the right side and Kaplan-Meier curves, you see as the number of these points increases in individual patients, there is a likelihood that the patients may experience disease progression increases as well, and the graphs moves towards kind of the lower part of the poorer survivals of these patients. The blood biomarkers are also important. So there are a couple of promising ones. So the PPQ or PRRT prediction quotient is basically an integration of gene expression and grading of the tumor, and is a signature of radiosensitivity of the tumor. The patients are divided into either have PPQ positive or PPQ negative, and it seems that it actually predicts very reliably the response to the treatments, up to 97% in these 3 validation cohorts in this study, which is led by Dr. Baudet. And NET test is a 51 multi-gene assay based on PCR analysis, and it's used for the response monitoring. And it's also has shown very promising compared to the imaging-based response assessment, very high accuracy of the NET test. Also important to note, we have molecular imaging biomarkers, particularly FDG, and the advantages of the kind of PET scans and FDG is a non-invasive test. It can be done multiple times in a whole body scale and in a real time. And in this study, we see that the FDG in even G1 and G2 patients could differentiate the patient better than Ki67 in a whole body scale. And the patient who had FDG-avid disease had poorer survival compared to those patients who are FDG negative. And even in response to PRRT, we see patients who have FDG negative disease has better response compared to the patient who have FDG positive disease. Dual tracer imaging is also important. We know that the somatostatin receptor imaging is a predictive marker for response and is a gatekeeper for patients to be treated with lutetium dotatate or somatostatin receptor-based treatment. This study is done by Australian colleagues, and we see, based on dual tracer imaging, patients grouped to 5 different groups as compare head-to-head the somatostatin receptor PET and FDG PET. And when we look at the survivals of these patients based on their group, we see the patients who don't have FDG-avid disease with high somatostatin receptor expression have the best overall survival probabilities compared to the patients who are FDG-avid disease but do not have a somatostatin receptor expressive disease. And also basically help us also to choose patients who might benefit the most from the PRRT. And also, while combining these 2 tracers, we could risk stratify the patient who might be benefiting from more intensified and surveillance and follow-up as well. So what is new in PRRT? PRRT is now entered multiple randomized clinical trials, to explore its optimal timing and sequencing of the treatment, and also expanding its indications to other neuroendocrine tumors, including bronchial and paragangliomas. There is a critical need to enhance understanding of the radiobiology of lutetium dotatate and PRRT to optimize and hopefully individualize this treatment. Rational combination strategies have shown promising preclinical results. An increasing number of early phase clinical trials are currently being conducted with different agents. We see promising advances in the radiochemistry and radiopharmacy and physics, which may pave the way for the new generation of radiopharmaceutical with an enhanced therapeutic index in the near future. And finally, clinical blood and imaging biomarkers need to be integrated into the clinical decision-making and also hopefully in the clinical trials at various stages of the disease. Thank you very much for your attention.
Thank you, Dr. Iravani, for that very thorough and informative presentation. As you know, this is personal to many of us, myself included, as my husband has had PRRT and was retreated. And we're very curious about all the latest in PRRT. So thank you for sharing your experience and the advances of this.
Thank you for the opportunity. It was my pleasure.
Yes. Well, we have about 45 questions, and it's not possible to get to all of them. So we're going to do our best and jump in right away, if that's okay with you. Okay, we're going to start with a question that's about scans because it is related to PRRT. And the question is, when might you order a copper dotatate scan versus a gallium dotatate scan? And if someone had a gallium-68 dotatate, is it better to keep doing that or to switch to a copper scan? And do serotonin-based medications affect DOTA scans?
Right, it's an important question, and we get asked quite frequently. The short answer is the copper dotatate and gallium dotatates are interchangeable from my perspective, and from the diagnostic point, from the patient perspective as well. Although there hasn't been like head-to-head comparison with the gallium dotatate and copper dotatate, there has been comparison with the copper dotatate with another gallium dotatate agent, which with similar properties compared to dotatate. So I think clinically they are equivalent. It might be wise if someone's already had gallium dotatate and they want to follow their response to the treatments, they can just keep doing the same tracer that it used. Like if they had previous gallium, they could continue with the gallium, or copper, they could continue with the copper. But I would think the access is issue as well. If a particular institution's using one of these agents or have access to one of these agents, they could use that as well as the clinical. But I don't particularly think you would prioritize one to the other.
Thank you for that. And what about serotonin-based medications? I've heard this question asked before. Do they affect dotatate scans?
So there are multiple studies what has been shown that it's to some extent it changes the biodistribution of the tracer. So we see after starting long-acting somatostatin analogs, after these particular agents get to a steady level in the blood, we see that it blocks the normal organs, particularly liver, spleen, and other organs like thyroid, and their uptake decreases, and it provides more availability of the tracer to the tumor site. So we have kind of higher conspicuity of the lesions compared to the background normal organs. When these drugs are used for like somatostatin analogs are used for a long period of time, the impact is less because these drugs get to the steady level into the bloodstream, and the impact is less on the changing kind of conspicuity of the lesion. So it's very important for physicians who interpret these studies to know whether the patients are chronically on these agents or just been started, particularly when the first scan after the starting these medications are when we see the most impact. So when we interpreting those scans as to comparing to when the patient wasn't on the somatostatin analogs, is important to consider that fact.
Yeah, timing is important. Thank you. So there's several questions about counts, and I know this is a question that you might talk to your patients about as well. So when people talk about low counts as a side effect of PRRT, which ones are you talking about? And what labs do you check, and which ones are the ones that are concerning to you? And what precautions or treatments can be done?
So the blood counts are basically white cell counts, red blood cell counts, and platelets. So those are, when we're referring to the counts, we're referring to those kind of hematological tests we do. And we see, particularly with the radionuclide therapy, the ones which appears to be more sensitive is platelets. One of the most common one which drops, although hemoglobin can drop as well. In about 10 to 15% of the patients we see, they might have some degree of drop in about 4 weeks after the treatment, which usually they recover by the next cycle of the treatment. The one which are concerning is the ones which have a deeper drop, like the percentage of the drop in the platelet counts or white cell counts are kind of larger drop we see in them, and for a more prolonged period of time. Those may kind of raise some indication that that particular patient might be radiosensitive, like the bone marrow of the patient might be a little bit radiosensitive. We don't have any like precautionary things that we could do. So it's a lot of susceptibility of the particular cells, and bone marrow cells appears to be the main factors. Although, I mean, the extent of disease in the bone is important because we may have some crossfire from the lutetium dotatate to the normal marrow as well. And what particular treatments the patient had. For instance, if the patient had multiple lines of treatment previously, or if particularly chemotherapy or alkylating agents, they may put them at higher risk than they may have hematological toxicity.
Okay, thank you. And there's a couple questions about if those counts would ever recover. And, you know, I'm going to group it with this question about NDS or and if you could define it, what is this? How do you test for it? When would you see it? And when are signs and symptoms?
Sure. It's very important questions and very important factor that the patient needs to be always discussed with the patient. So what is MDS? MDS is myelodysplasia. It's a heterogeneous syndrome, which basically the bone marrow cells or stem cells are ineffective in producing the normal red cells, white cell counts, or platelets. And it's heterogeneous. So there are different factors involved. And particularly the one we're referring to is the MDS, which is associated with treatments or treatment-related MDS. So there are a lot of like bone marrow cells within the bone marrow or stem cells, but they're not effective in producing normal cells. So they don't perform normal activity that they need to do. For instance, they're not enough active platelets, or which prone to bleeding, or white cell counts, or normal white cell counts, which prevents us from getting infection, or normal red blood cells, which carry the oxygen. So those cells are basically ineffective in producing normal cells, and predisposing the patients to particular complications. The other factor is the MDS is a precancerous condition. So some of these MDSs, particularly treatment-related ones, could evolve into leukemias. And the higher the risks are, which based on the genomic analysis and other factors that the hematologists consider to risk stratify the MDS, there's a higher chance that they could evolve into AML or leukemias, which particularly in the context of treatment-related MDS carries a poor prognosis. With limited options, and this seems to be more resistant to treatment compared to an MDS, which is not related to the treatment, or like, for instance, chemotherapy or radiation. But it's important to consider that the risk is low. Though we're talking about, I mean, at least with the NER1 trial or other registry studies done outside of US, the risk is in the range of 2% or lower. The risk is low, so that's always basically considering the risk and benefits of this treatment when we're suggesting it to the patients.
Okay. When after the treatments would you start seeing this, and what are the signs and symptoms?
There have been studies done. They've looked at whether we could predict which patient may develop this complication. Unfortunately, we currently don't have any kind of a a robust predictive factor to see which patient may develop MDS. There are some early indications in some studies been proposed. For instance, when the patients during the treatment have cytopenias or the counts drop during the treatments, that might be an indication that they may develop in the future. Particularly, some studies look at the platelet counts. When the platelet counts drops, there might be a factor that to consider. So generally, in patients who have a deep drop in their blood counts, we have to a little bit be more careful and more kind of doing more intensive surveillance for those patients. And if particularly those counts don't recover to normal level, or it's a for more prolonged period of time, that's when, for instance, more than 6 months or up to a year, then that's the time we may think about more to do investigations. Some other things to consider. Sometimes we see patients have, because of like neuroendocrine tumors, they removed a large part of the bowel, so they have some absorptive issues, like for instance with vitamin B12 or others. So there might be other factors as well which easily correctable if could be picked up. So it's important to do all those investigations to make sure that none of those are explaining like anemia, which could be corrected easily.
Yeah. And surrounding that question of when would you see it, do you tend to see it like within so many months after the first treatment, or after like multiple treatments? At what point in the cycles or treatments do you see it?
Yeah, it's usually happens sometime, I mean, kind of in the range of 1 or 2 years after the treatment, after finishing the treatment. So it's not an early event. Most cases, like the patient had PRRT a year or 2 years before. So that's the timing that may happen when they drop. Some of the blood counts may start to drop at that time point. So it's a longer term follow-up is important for these patients.
Okay. And I'm just curious around this, because if you have 4 treatments, does it go up? Or does the risk go up with more treatments?
And not particularly. I think they have looked at the there are study we did a study over 500 patients that at the Peter MacCallum Cancer Center looked at what could be predictive, and there wasn't any particular relationship with the number of the cycles that the patient received, obviously, but I mean, theoretically, the more cycles of treatments, I'm talking about more than 4 cycles, like when we go to the retreatment phase, there is increased cumulative increased radiation absorbed those to the marrow and potentially increased risk of the marotoxicity, long-term marotoxicity. But I think the most important factor here is whether that patient or that the bone marrow of the patient is particularly sensitive to radiation. That appears to be a determining factor. So that's currently what we know. There are a lot we don't know. We really hope that we could kind of doing more kind of genomic analysis on the patients who develop MDS to drive those factors that we could initially predict which patient, but currently there is little knowledge of understanding why this happens, in which patients really happens.
Thank you. That also explains, all this work towards clinical trials, right? So that you can learn more and better answer some of these questions. Okay. So speaking of retreatment with multiple, this is a very popular question with the viewers regarding retreatment or salvage treatment with PRRT. How long is it expected to work, especially when you compare it to how PRRT worked the first time?
Yeah, as I presented in the slides, there has been a few studies looked at the retreatment, and the average benefit in those kind of retrospective studies is been with the range of like 12 months of disease control and not allowing the disease to progress, which is a little bit shorter than the initial kind of response, although this has been in a heterogeneous group of patients and different treatment settings. So we can't really extrapolate a lot from these studies, but it seems to be 12 months, which is very promising. I think 12 months of disease control for retreatment is very promising, although it might be shorter than the initial benefit. And I think if I want to talk to my experience, I think the after retreatments, because this is going to be new in the U.S., so the patients just reaching to the point at getting retreatment, but outside of U.S. patients being treated, and like in the institution at Peter MacCallum, the patient had multiple retreatments over time, and they equally benefited each time, but it seems every time the duration of the response becomes a little bit shorter compared to the initial benefit. And whether because we're just selecting the tumor clones which are a little bit more resistant to the treatment, that's something that needs to be also looked into in more details. But retreatment is a very exciting, I think, trial, and we're very excited to that be open and provide the prospective data compared to the standard of care, so we could know how we could sequence and use it more intelligently.
Yeah, thank you. Actually, there is a related question. You're talking about how people get multiple treatments in Australia. How many cycles of PRRT are possible, and where is the limit, if you know?
Yeah, so it's very important questions. It's difficult to answer. How many? I mean, personally, I don't think there is any kind of upper threshold of how many the patients can get. But it depends on how the tumor respond and how the bone marrow or other toxicities may happen during the treatment. Like outside of Australia, outside of the US, I've seen patients receiving even up to 10 cycles of treatment at different time points over years. But the oversight that we have in the US is based on also limitation of the normal organ dosimetry, as I kind of alluded into the talk that, like for instance, there has a limitation of 23 gray to the kidneys, which is extrapolated from external beam radiotherapy, not particularly from PRRT. And if that threshold reaches, then the patient might not be suitable for future treatments. But I think based on the biological effective dose, we think that 23 gray could be higher. And based on what one cycle of PRRT can deliver radiation to the kidney, potentially the patient can have more than 4 to 6 cycles of treatment. So yeah, we don't really know how many cycles a patient can get. We don't really have that limit, and we have to kind of consider many factors, including the response to the treatment, the benefit availability of other treatments, and how the body responded to the treatment.
Yeah, wow, that's very helpful and very interesting, and we look forward to hearing more with that. Here's another logistical question. Not everyone's getting retreatment. So if someone only received 3 PRRT treatments, I'm assuming with Lutathera or lutetium, they were unable to complete the 4th. Can they later receive a 4th treatment? And how many then would you retreat with?
I think if I just gonna kind of generalize this question, sometimes we see patients receive like less than 4 cycles, and they say, should we really receive all 4 cycles? And do we really need to get the most benefit from the treatment? But when you look at how this treatment is evolved, I mean, if every patient is different, and every patient would respond differently. So we have to keep open-minded that maybe three cycles of PRRT maybe would be as effective as 4 cycles for a particular tumor. Although the evidence on NETTER-1 or other trials is mostly from 4 cycles, but there are other factors to consider, including the dosimetry to the sites and how the tumor responded to the treatment. But in answering specifically about this question, yes, I mean, the patient can have it later on as a retreatment. I don't think there is any problem for the patients to get. If the initial 3 cycles had shown benefit for the patient can have future cycles, or basically when it's needed. What I would suggest here, if the patient had prolonged period after the 3rd cycle, they may assess the response to the treatment and decide whether we could use it later on if the patient had benefit from the initial 3 cycles.
Thank you for that thoughtful response, and sounds like it needs to be individualized. And speaking of the treatment delays, what is the longest that a treatment can be delayed?
Yeah, so I mean, there's some guidance. Good question. I think there's some guidance from insert package of Lutathera, and if particularly the treatment is delayed because of the low blood counts and toxicities, there is a certain limits for the number of the weeks that could be delayed. I would say again, it's an individual decision. I think this is a individual case that needs to be discussed with the physician. It's important to know how well, how much the patients benefited from the initial treatments or initial cycles, and what is the goal of the treatment. So if the goal of treatment is, for instance, disease control, if we have achieved that, then with the initiation or observance of toxicity, maybe we could think about maybe stopping it at the moment and wait and deferring that treatment to when it's needed, rather than just being following the exactly kind of the treatment schedule. So again, it's important to individuals based on many factors, including efficacy and toxicity, and what the goal of treatment is.
Yeah, thank you. Thank you for that answer. So this question comes up quite often. Can PRT be done for tumors in the mesentery? This particular person was told the risk of bowel obstruction was high, and therefore she wasn't a candidate, or he or she is not a candidate for PRT.
It's a very good question, and it's a very challenging. I would say when the disease is in mesentery, it's challenging to treat, not only for PRRT, but for any treatment. There are a couple of factors. There are different types of peritoneal disease. I would say mesentery and peritoneal disease. There are different types. There are certain types which respond, and there are certain types which do not respond. And a particular one is when we have a large kind of mesenteric mass, which kind of causing a lot of mechanical issues, for instance, obstructing the vessels, causing engorgement of the bowel, or the lesion is causing tethering of the bowel because of a lot of fibrotic changes, and which is in reaction to the tumor and the products of the tumor, and kind of tethering all the loops of bowel, causing obstruction. So those are, although it's an oncologic problem, but also it can kind of considered a mechanical problem as well. Like these are very difficult. I'm not with the treating with the PRRT. So in a kind of a smaller studies, and most of them retrospectively, they've shown like sometimes extra radiation, which is delivered by PRRT, could kind of increase the fibrotic reactive changes within that tumor microenvironment, and that could also precipitate a bowel obstruction or more congested bowels, and causes bowel ischemia or those issues. So although it's very difficult to prove that, but that is something to consider. And it's very difficult to know whether this is going to be a natural process of the disease, then disease is going to progress anyway to that stage, or whether the PRRT is actually kind of expediting that process by increasing more fibrotic changes in a tumor which has caused a lot of fibrotic reaction.
Okay. So then what can be done regarding PRT for the mesentery if it's given?
Yeah, so I think it's important to talk to again, at the multidisciplinary team meeting, to be presented and talk with surgeons. Sometimes some of these tumors can be resected, particularly if they're close to obstruct the lesions, and earlier on might be easier than later on, because of these tumors become harder to treat later on. So it's important to see whether it could be surgically removed, and that potentially then the PRRT can be pursued. So those kind of can be discussed. Sometimes interventional radiology can also do procedures that can open up the vessels, which might be getting narrowed by the tumor. That's also a potential that can be discussed.
Multidisciplinary team. That's always
Yes,
helpful. Yeah.
absolutely.
What about PRT for those with severe kidney disease?
Yes. Again, it's an important question. So we know these a lot of clinical trials that we have did not include these patients. So we don't have much prospective data on patients who have severe kidney impairments. I think everyone in the clinic, they're actually treating these patients, and depends on the degree of kidney impairment. So there are calculations to filtration rate of the kidneys and called GFR. We usually like that the GFR or kidney marker of kidney function be above 50, but we see patients below 50, like in the range of 30 to 50, that we still treat these patients despite the reduction in the kidney function. What is important to consider in these patients, because the kidney is the main organ which clear the peptide and the lutetium dotatate. So they basically, if the kidney function is impaired, the drug is gonna be circulating in the body for a longer period of time than a patient with a normal kidney function. So that exposes the normal organs, particularly the bone marrow, to more radiation. So particularly in these patients, is important to closely monitor the blood counts and potential hematological toxicity after treatment. But it's still, I think, it can be considered in patients who produce enough urine and they could clear the tracer. It's still effective treatment.
Thank you. And I know you touched on this a little bit in your talk, but what is the effectiveness of beta PRRT, so Lutathera, such as the improvement after treatment in NETs? And what's the effectiveness expected to be with alpha PRRT?
So as I alluded, it's a very important question, because now we're entering the phase that the alpha is becoming available, at least in the clinical trial settings. And there was very kind of promising data coming from alpha PRRT. As alluded, there are major differences between beta and alpha. Alpha has a shorter path length, which delivers more targeted radiation to a smaller kind of radius around that where it's deposited with a much higher energy. So a much smaller amount is needed to cause that damage to DNA. At the same time, we have to consider this is also going to be true for normal organs as well. So not only is more effective in treating cancer cells, but also in organs that expresses the somatostatin receptor may be causing more toxicity as well. So it's always a balance. I think we have to consider that. That's why we need to have a longer late data. But it's hard to really put a percentage of how much better is alpha compared to Tera, but by the rules of the physics, we say if you need like 100 hits to DNA by a beta, we only need 10 by the alpha. But again, these are all the rules of physics needs to be proven in the body and the human. So it's very promising. I think it's a very promising field, and we're getting very promising data.
Yeah. So the theory sounds really good, and we need the clinical trial data.
Yeah, we need a clinical trial data. Yeah, and there are challenges with alpha, as mentioned as well. So there's some alphas that they have some daughters which may be in the blood, and after they get unbound from the peptide, we don't really know where they go and what toxicity they can cause. So that's important to know the longer term toxicities as well.
Yeah, thank you. And a related question, when will alpha PRRT be available for everyone? This question was asked in multiple ways in the US for everyone. And if you were given a choice, would you do alpha PRRT or beta, and why?
A difficult question. It's difficult questions because there's limited data now. The first phase 3 trial is going to be open very soon. So that would take a few years to recruit the patient, and then we can read out the clinical trial data and having enough follow-up. So I think for the foreseeable future, for the next few years, we'll have alpha therapy on trials, which I think is best to be on the trial as well until we know exactly how effective and safe it is. Then that's the time to basically make a choice between alpha and beta when we have a complete picture of the effectiveness and the safety. But again, as I said, theoretically, it looks very kind of appealing to have alpha. But again, something to consider. Maybe in the future, what I'm considering as well is maybe in a higher risk patients, you may consider alpha. In higher risk patients with the lower expression of receptor, when we need lower hits, lower kind of hits of the DNA, maybe alpha is an option which would help compared to the other patients. But again, those are unanswered questions that we need to work on.
Thank you. Here's another logistical question. If someone has 6 PRRT, so I'm assuming Lutathera, can they later get alpha PRRT?
On a clinical trial, possibly, I think. Again, it's if they had 6, because what the trial is kind of designed, they put a limit of the minimum number of cycles they need to have, but I don't think there is any limit on the maximum number that they had previously. But I think it's possible if they had disease control and didn't have much toxicity, and they could be considered for alpha PRRT trial.
Okay, thank you. What about this question? Besides the lead-212 and the actinium-225, which you talked about, what other alpha therapy is being studied in NETs?
So these two appears to be the most promising one that's been used most extensively, particularly actinium-225 has been, you see a lot of agents. Lead is a promising. There are other agents as well which may come, but currently I think it's important to focus on the ones which are more accessible and more common, and we have clinical data. If you looked at my slides, there was astatine as well, which is a promising alpha agent. It has a little bit of complex radiochemistry, but I think it's something that could be overcome and it could be labeled. So astatine is an interesting agent as well. It's relatively clean. It doesn't have any daughters, which can cause potential unintended toxicity. The access is issues because the cyclotron produced agent, only limited number of cyclotrons in the world we have that could produce enough astatine. So that's one of the agents that potentially would be interesting to look at in the future. We have bismuth as well. Bismuth has very short half-life, very short half-life. That's make also is a potential option, but its access is issue, and so have to have a very kind of a facility that they can use it immediately. So
yeah, I know we talked a lot and in your presentation and already in the Q&A about alpha PRRT, and you've touched on pros and cons, but I guess just to summarize, and you could generalize this question, what are the pros and cons of alpha PRRT? And in particular, there was other questions related to side effects as well of alpha PRRT.
Yeah, so the pros and cons particularly is, I mean, there is limited clinical data, so we need a larger cohort of patients with a longer follow-up to exactly know how effective, although the preliminary data so far has been very promising and compared to the beta emitters. But if it becomes clinical practice, so depending whether the alpha or beta may be a matter of access to the drug as well as the risk profiles that we could drive from the clinical trial. So how we're going to intelligently sequence it, alpha versus beta. It seems to be very promising or appealing after the patients progressed on beta emitters. So that could be a logical way we can think about, and that's how the phase 3 trial has been designed, until we get longer follow-ups and we're completely sure about its longer kind of follow-up and safety. And again, in the upfront treatments, maybe at some point we can look at the patient who have a higher risk of progression on the lutetium or beta emitters and with the lower expression of the targets. So maybe those patients are potentially use them upfront.
Thank you so much. There are so many questions. I feel like I could keep talking to you for a long time, but we're just going to end on this closing question. What are you most hopeful or excited about in the field of NETs, given all these advancements, the clinical trials that are open, everything that you're working at as well?
Yeah, it's an interesting question, because when I was preparing the presentation, I was looking, wow, how much progress has been made. Like, look at how much we could talk about, even within the narrow field of lutetium dotatate or a new radionuclide therapy for NETs, how much progress has been made. We have improvement in the radiochemistry, we have different radiopharmaceuticals, we have alpha treatments. There are lots of combination treatments synergistically, which are very appealing, and I think it's one of the very exciting that with the increasing tumor heterogeneity, we do really need combination treatments, and how we could kind of synergize the treatment. The biomarkers are exciting, like the biomarkers which predicts the outcome from the outset. We could risk stratify the patients with the imaging biomarkers, so we know which patient might benefit, and we could potentially intensify in treatments and choose the treatments which appears to be more effective in that particular patient. So we're entering a realm of individualized treatment, I'm hoping, with biomarkers. So I'm very hopeful that we could individualize treatment and choose the best treatment at the outset for particular patients based on all the tests that are available.
Thank you so much. And this really shows, the progress that's been made is remarkable. It's hopeful. And this work in the clinical trials is the way to answer these questions. I know there were more than 45 questions that came in. Not all of them were answered. Many of them are probably not satisfactorily answered. And what we can all do as a community is try to move the process forward as patients and caregivers enrolling in trials or talking about them. And then thank you for all the work you're doing to open the trials, to work on dosimetry, to advance the field forward, and just all your hard work and dedication. It's remarkable, and we're very deeply grateful for you.
No, thank you very much. I was really honored to be present this, and it was very very informative for myself, and I'm really hoping that we could all work together to improve the patient care and outcome for neuroendocrine patients.
Yes, that's our hope too. Well, I'm going to turn it now over to Kavya in the studio.
Thanks to our speaker, Dr. Iravani, for that informative presentation and answering those important questions from our live audience. Thanks again to our supporters, Advanced Accelerator Applications, ITM Pharmaceuticals, Lantheus, and Neuroendocrine. Thanks to our technical director, Rich at TVP Live, and to all of you for joining us today. LACNETS depends on donations to bring you programs such as this educational event. Please consider making a donation at lacnets.org/donate. Again, follow us on social media to stay up to date on our upcoming events and NET news. Our Twitter handle is @LACNETS. Now back to you, Lisa.
Thank you, Kavya. We want you to know that you are not alone. LACNETS is a community of support and resources. We offer many programs, including our weekly virtual NET support group, our monthly caregiver-only support group, NET Vitals, which is our NET communication tool, and a health and wellness coaching program. LACNETS also has a monthly podcast featuring experts who answer the top 10 questions in their field. This month, we are releasing a podcast on gastric NET, gastrinomas, and Zollinger-Ellison syndrome. Go to our LACNETS podcast page to check out the transcript, resources, and the 10 questions we asked the expert. LACNETS is here to help you and those affected by NET. If you have questions or are looking for more resources, you can reach out to us on our support line at lacnets.org/support line. Thanks again for joining us. Goodbye and see you on May 4th.